Welcome to Doctor's Desk. Today I'll be talking about Kawasaki disease, which occurs in pediatric population. So it's an acute self-limited medial vessel vasculitis that predominantly affects young children and has a special predilection for the coronary arteries. So I'll be talking under epidemiology, etiopathogenesis, its clinical criteria, investigations, treatments, and its complications. So before going into other stuffs, I wanted to know you the history. So Kawasaki disease was first described in 1960 by Dr. Tomisaku Kawasaki, a Japanese pediatrician. He observed children presenting with prolonged fever, rash, and enlarged lymph nodes, which did not respond to any antibiotics initially. This condition was termed as mucocutaneous lymph node syndrome. And in 1974, coronary artery aneurysms were identified in affected children, establishing the cardiac significance of the disease. Since Dr. Kawasaki noticed this strange illness, his name was kept for this disease after him. Coming to the epidemiology, Kawasaki disease primarily affects children under 5 years of age, with a peak incidence between 6 months and 5 years. So it is more common in boys than girls. The highest incidence is seen in the East Asian countries such as Japan, Korea, and China. So there is seasonal variation is noted with higher incidence in the winter and early spring. Then the for etiopathogenesis, the exact cause of Kawasaki disease remains unknown until now. So it is believed to result from an abnormal immune response in genetically susceptible children following an exposure to an environmental or infectious trigger. So genetic associations include polymorphisms affecting the immune regulation and inflammation. So there are some possible etiological factors like infection triggers, environmental factors, family history, then genetic susceptibility towards inositol triphosphate 3 kinase C, so which is a gene involved in activation and inflammation. So pathogenesis, in acute phase, the activation of innate immune system occurs through toll-like receptors on macrophages, dendritic cells, and endothelial cells. This leads to activation of NF-kappa B, release of inflammatory cytokines, and neutrophil infiltration of vascular walls, causing endothelial injury. This acute inflammation and endothelial damage occurs between day 0 to day 10. Then phase 2, in subacute phase, the macrophages, T cells, and inflammatory mediators infiltrate all the layers of coronary artery, and there will be cytokine storm involving interleukins and tumor necrosis factor, which leads to progressive weakening of the atrial wall. In the phase 3, which is in the convalescent phase, breakdown of elastin and collagen occurs, leading to smooth muscle cell apoptosis. So this results in arterial wall dilatation, aneurysm formation, and potential long-term coronary complications like aneurysms, and sometimes aneurysm rupture can also happen. So destruction of atrial wall integrity and progressive atrial wall dilatation occurs after 21 days, which is in convalescent phase. So this is a simple diagram or the chart to represent the acute, subacute, and convalescent phase. Coming to the diagnostic criteria, so Kawasaki disease is diagnosed based on fever lasting 5 or more days, along with at least 4 or 5 principal clinical features. So first, oral changes. So oral findings include erythema, dryness, fissuring, and crusting of lips, diffuse mucosal erythema, and classically they call it as strawberry tongue due to its prominent papillae on the tongue. Then next is conjunctival changes like bilateral, painless, non-exudative conjunctival injection with limbal sparing is characteristic feature. So purulent conjunctivitis suggests an alternative diagnosis. And rash, a maculopapular erythematous rash that begins classically from the trunk, later extending to extremities and the face, which is usually seen by 5 days of onset of the illness. Then cervical lymphadenopathy, which is typically unilateral, non-suppurative, and greater than 1.5 centimeters in diameter, like more in anterior triangle of the neck may be noted. Then extremity changes like in acute phase, erythema and edema of the palms and soles are seen, and in subacute phase, periungual desquamation of fingers and toes occurs. Other common, these are uncommon clinical manifestations which are like irritability, like aseptic meningitis, arthritis, sterile pyuria, like urethritis, and gastroenteritis, abdominal pain, vomiting, and diarrhea. Then BCG reactivation, uveitis, perianal or periungual desquamation, and gallbladder hydrops and jaundice. So these are the uncommon clinical manifestation occurs in Kawasaki disease. Then coming to the criteria for investigation, previously we saw the criteria for clinical manifestations. We are going to see the criteria for investigation. First, in complete blood count, there will be some mild to moderate normocytic normochromic anemia, which includes polymorphonuclear leukocytosis and thrombocytosis, which classically occurs in second week of illness. And then acute phase reactants like ESR and CRP are always almost elevated. And then elevated serum transaminases, then hypoalbuminemia and hyponatremia, then sterile pyuria more than 10 cells per high power field with sterile culture. Then serum pro brain natriuretic peptide and N terminal pro BNP levels are elevated in Kawasaki disease, and serum levels of anti-pro BNP more than 2 to 5 pg per ml can assist in diagnosis of KD. So this NT-proBNP levels are always elevated and can assist in diagnosis. So in ECG, it may show myocarditis or conduction abnormalities, and in again ECG is essential for diagnosis and risk stratification and follow-up. So for uncomplicated Kawasaki disease, the timeline is around we have to check the ECG at diagnosis, then 2 weeks after the fever onset, then again 6 to 8 weeks after onset. And for complicated Kawasaki disease, it should be like serial echo, like from at diagnosis, then 1 to 2 weeks after fever onset, then again 2 to 3 weeks after fever onset, then later 6 to 8, then every 6 to 12 months it should be repeated frequently. Then, so this is the Z score interpretation. This Z score is basically the coronary artery dimensions calculated in pediatric population. So which helps in tracking the size and risk stratification. So Z score is calculated by observed value of the patient minus mean value of the pediatric population divided by standard deviation. So the interpretation of Z scores are, if it is less than 2, it's normal. If it is 2 to less than 2.5, there is slight coronary artery dilatation, requires close monitoring, and 2.5 to less than 5, It's a small aneurysm, low risk of complications, and follow-up is needed. It is must. And around 5 to less than 10, which is medium aneurysm, moderate risk of complication, and long-term follow-up is must. And more than or equal to 10, which is large or giant aneurysm, there is high risk of thrombosis and stenosis and myocardial infarction. So the kid or the boy or girl can die easily. So diagnosis: in the presence of fever and coronary artery involvement on echo or less than 4 by 5 criteria is sufficient for the diagnosis. So in 25% cases, presence of coronary artery aneurysm is diagnostic. So there are some exceptions like incomplete Kawasaki or atypical. Incomplete means it presents with the kid presents with a fever and fewer than 4 clinical criteria, but supportive laboratory or echo findings. In atypical Kawasaki disease includes unusual systemic involvement such as renal or pulmonary manifestations. So coming to the treatment part, so the main goal is to control the acute inflammation and prevent long-term coronary sequelae. So treatment should be initially promptly and must not be delayed awaiting for echo. And so the single dose of IVIG 2 gram per kg administered over 12 to 24 hours plus high dose of aspirin used in acute stages is 30 to 50 mg per kg per day in 3 to 4 divided doses. That is continued until the patient is afebrile for 48 hours. The dose of aspirin is reduced to 3 to 5 mg per kg per day and continued till 6 to 8 weeks and stopped if coronary artery aneurysms are not detected the 6th week of echo. So the antiplatelet dose of aspirin is continued in the patients who have persistent coronary artery aneurysms until the normalization of coronary artery dimensions. If fever still persists, steroids with IVIG can be used, like oral prednisolone 2 mg per kg per day to be initiated with IVIG and gradually tapered over 15 days after normalization of CRP levels. Or instead of oral prednisolone, we can use methylprednisolone IV on day 1 to 3, followed by oral prednisolone until afebrile and CRP normalized. Then slowly we have to taper over a few weeks, like 2 to 3 weeks. Then IVIG responsive patients, fever usually subsides by 36 to 48 hours, along with the decrease in inflammatory parameters like ESR and CRP. Patients with recurrent Kawasaki disease is defined as repeat episodes of Kawasaki disease after complete resolution of first episode should receive standard therapy of IVIG and aspirin. So basically, if the kid uh, recurs with Kawasaki disease, we have to repeat the same standard therapy for the kid. So that is called recurrent Kawasaki disease. So there is something called resistant Kawasaki disease. So the children who have persistence or recurrence of fever 36 hours after the end of IVIG infusion are considered to be IVIG resistant. So many experts recommend retreatment with second dose of IVIG, but there are some drugs like infliximab is a chimeric monoclonal and anti-TNF alpha antibody. The dose is 5 mg per kg given intravenously over 2 hours, and plasma exchange used rarely for the children who have acute inflammation despite multiple doses of IVIG, corticosteroids, and infliximab. So a recent study says statins may have therapeutic benefits in KD patients. So the The last extreme thing is plasma exchange, which where despite giving the IVIG, steroids, or monoclonal antibodies, the last resort is plasma exchange. So the complications are include Kawasaki shock syndrome, macrophage activation syndrome, coronary artery aneurysms, thrombosis, myocardial ischemia, infection, and sudden death. So long-term management focuses on preventing thrombosis, myocardial ischemia through antiplatelet therapy, beta blockers, ACE inhibitors, statins, and long-term cardiology follow-up. So the conclusion is Kawasaki disease is a pediatric vasculitis with potential fetal fatal cardiac complication. Early recognition, prompt treatment with IVIG, and close cardiac monitoring are essential to improve the outcomes. Surgical management is very rare in a pediatric age group. It includes percutaneous coronary intervention or coronary artery bypass grafting. Thank you and have a great day.